Thanks, Beth. I think I have to lobby next time not to follow the raffles because there's like 2 happy people in the room and like everyone else just lost a raffle. So, anyways, thanks everyone. I think this is a great thing to be a part of. I'm always, in awe of the kind of time dedication that people have to come here to learn about these things. It really, I know it all ultimately funnels down to your patients, and I think it's remarkable. Certainly, I can speak for the nurses and techs. They're a vital part of the team that take care of patients, and it's an amazing thing. So, anyways, I'll jump right in since the clock is definitely running. I don't know how to work this. Do I just press? Okay, perfect. Oh, cool. All right. So, disclosures. I consult for those companies. So here's a brief outline. We'll go one by one here. We'll start with a brief history of Radial, and it's something that just really makes sense. So way back in the 40s was the first radial angiogram by cut down. We used to use, this probably precedes everyone here, myself included, 8 to 10 French catheters, which is obviously too big for the radial, so not part of it. But as things miniaturized, Dr. Campo, who's unfortunately recently passed, reported the first series of percutaneous transradial coronary angiograms. 1993 was the first stent placement, Dr. Kemeny. What's the rationale? Well, we use advanced antiplatelet anticoagulation therapies, particularly for ACS, to reduce ischemic outcomes and help patients. But that causes a bleeding risk, which is infrequent but still significant. And bleeding, as we'll see, is associated with really bad things. And transradial interventions really reduce bleeding, so there's a decent rationale there. In addition to that, it improves patient comfort and convenience, as you know, immediate ambulation, reduced inpatient time and costs. So what about bleeding? This is data from the NCDR, which is a massive database. It really just shows one point, that everybody who gets an invasive procedure bleeds. Bleed at different rates depending on your presentation, but everyone bleeds. Stable, non-STEMI, or STEMIs. And a good proportion of each of those groups, the bleeding is access site related. So, okay, what's the big deal with bleeding? Usually patients do okay, but what's kind of the long-term effects of this? So this is data from 10 studies here, that if you bleed with your ACS, now this isn't transradial, otherwise it's just simple bleeding, you're 7.5 times more likely to die. Of course, this is a marker, sicker patients may bleed, but it's still a deep association with outcomes. This is where you bleed, access versus non-access site bleeding. Now, of course, non-access GI bleeding, intracranial bleeding is going to be much worse, but still adjusted access site bleeding is 1.8 hazard ratio for harm. It's not just dying. There's a higher risk of MI and stroke. This is pooled data from several old ACS trials, but the point still holds. 4, 5, 6 times more likely to have these awful events. So it's kind of a big deal. And what about TR versus TF effects? This is a meta-analysis, and this is really not debated. And I don't know, everyone's in different labs and have different operators that have different preferences, but there's really no debate here that if you go by the risk, you're markedly reducing the risk of access site bleeding. 73% reduction. This is pooled data. This has been repeated really ad nauseum. So there's a rationale and history there. Now, what about the real data? And it's been mounting, and it's powerful, actually. So really things started moving in this country after the Radial study, which many of you know, 7,000 patients, prospective randomized ACS patients to TR or TF procedures. They looked at MACE, ischemic outcomes and bleeding, so combined outcome NACE. Now, while the trial was kind of technically equal between the two, when we looked deeper into it, it really showed the value of transradial PCI. So the primary outcomes were similar. When we looked at the subgroup, before that, we'll talk about the access site complications and bleeding were significantly reduced with Radial, as we had seen in past studies. Now, their definition of bleeding in the trial was really strict, or rather really high threshold to be called a bleeder. And you can see 0.5 and 0.5. There was no technical difference in the study, but most accepted definitions are much more, I would say, loose. And again, those rates would be way too small. 0.5% bleeding risk was way lower than what's real life in an ACS patient, markedly reduced by transradial. When we looked at the subgroup analysis, the STEMI patients in that group, we saw something pretty interesting, that the STEMI patients did have a significant improvement in the primary outcome, with radial versus femoral. But when we look closer, it was actually driven by death, the hardest of all endpoints, a 2% reduction, absolute reduction in death in the TR group amongst STEMI patients. Again, this was kind of hypothesis generating since it wasn't how this trial was designed to start out with. But based on this, other trials got initiated that were STEMI-specific radial randomized trials, one of which was a STEMI radial, 700 patients in the Czech Republic, 4 hospitals, radial versus femoral, where this is now all STEMI patients. Their endpoint was bleeding and access site complications. As you can imagine, a massive reduction. If you remember from the NCR data, the STEMI patients are the most likely to bleed. You're getting very strong antiplatelets. It's an emergency situation. So really marked reduction in bleeding outcomes. What about MACE? MACE actually trended in favor of radial, although it wasn't significant. When we added MACE to the bleeding, or bleeding to the MACE rather, you can imagine that bleeding was so profound that the NACE outcome was also markedly reduced in this group. So all, pretty profound findings in a prospective trial. Well, we like to repeat those, and that was done in Italy, a rifle trial, 1,000 patients for really experienced centers, very, very sick patients. Their findings were even more impressive. Primary endpoints of NACE, which again is combined ischemic and bleeding outcomes, 8% reduction, and the bleeding was 4 or 5% reduced. Interestingly, when we looked at MACE alone, without bleeding, there was actually a significant reduction in MACE. And again, these are combined endpoints, which are often driven by the softest endpoint we've known with prior stent trials and medication trials, that combined endpoints are generally driven by non-fatal MIs or target vessel revascularization, but this was actually driven by death, 4% reduction. Now, the rates are really high, but again, this was a trial that included every STEMI that presented. They could be getting CPR, they could be on multiple pressors and shock. So the rates were higher, and therefore the benefit was also theoretically higher. So a 4% absolute risk reduction. So remarkable findings. Again, all experienced operators. Interesting, it's important to note out that the bleeding was really all access, bleeding reduction was all access site, as you would expect. The needle really didn't move, I would say, until the Matrix trial came out, which was another large trial, 8,000 patients, complex randomization, but basically ACS patients, STEMI and non-STEMI, TR versus TF, and then some downstream anticoagulation randomizations as well. So in that trial, two primary endpoints, again, 30-day MACE and NACE, which is the MACE plus bleeding. Now, the MACE was significantly reduced, although it didn't meet their pre-specified significance level of 0.025, but 0.03 was still pretty impressive. When we added the bleeding, it was markedly positive trial showing a benefit of transradial. Again, 2.5% reduction. Concurrent with this, the trial has published a meta-analysis that really now pooled 20,000 patients that were all in randomized trials. So really no selection bias for which access they got. And what they showed was, we'll go to this part, that death was significantly reduced as a group. And some people were concerned that there'd be higher strokes going from the wrist across the great arch and the great arteries, but no difference in stroke. So there's more outcomes data. What about kidney injury? This was a sub-study of that Matrix trial, which basically showed that patients that got transfemoral procedures were more likely to get AKI with their procedure. And again, presumably through complications associated with their groin procedure, as contrast use is typically pretty similar. Interestingly, in that trial, it was actually the sickest patients that had the benefit. So those that started out with lower GFRs, older patients, KILIP 3 and 4, so sicker MIs, and those with that predicted CIN risks, contrast-induced nephropathy, by the Moran score of greater than 10. So there's kind of a little bit of a paradox. It's actually the sicker patients that drive the most benefit with respect to kidney injury and other things. So what's the transfemoral operators' counter-argument? And I don't know if you have operators that make these arguments. One is experience. Okay, sure, that the benefits were only seen in high-volume centers. And then another STEMI trial, the Safari STEMI, which was technically not showing a difference. We'll go into that in a second. So what about the experience argument? It's valid. You know, the difference in, this is in Matrix, was really only seen in the centers that had the highest proportion of radial PCI. So this is MACE and NACE. And if the center did 80% or more of their PCI transradial, they were a high center proportion PCI, radial PCI center, and that's where all the benefit lay. This is actually back to Rival. When they looked at operators with more than 150 radial PCIs per year, the primary outcome was also significant. Remember, the overall trial wasn't. So this doesn't mean only experienced people should do it. It just means that you should probably work to become an experienced operator, since these are really tangible benefits. To that end, the European Society has published guidelines of how to progress with simple procedures, planned procedures, then sicker, more complex procedures are pretty straightforward. Safari STEMI, that was another STEMI trial that was run. And again, I think that, well, I'll go over it first. So this was presented at ACC in 19. Basically, there was no difference. So 2,200 patients were ultimately randomized. There was no difference. This is not how they planned it. The DSMB had to stop the trial for futility. They had predicted at least a 4% risk of death, and that wasn't happening because they were taking really, really simple, straightforward, stable MIs. So showing that, showing that there wasn't a difference isn't really proof that there's not a difference. It's what we call a type 2 error. So really weighing that against 20,000 patients is pretty, it's hard to kind of make that argument. Little stroll down memory lane for those, again, I feel like many of them may not have had tons of experience with lytics and things like that, but we went through this in the Gusto trial, TPA versus streptokinase, a 1% absolute reduction. This is primary PCI versus lytics, 2% reduction, and this is mortality. Door to balloon, we talked about this mission lifeline stuff. We know that if you get to an hour compared to 2 hours, you reduce mortality. This is a 2% reduction that we've seen in these Radial trials. So comparing them all together, it's really on par to these paradigm shifting treatments. I mean, the whole cardiology world switched, when we had the data that proved this thing, and yet transradial for STEMI at least has lagged in this country. Let's get to that. US versus Europe, it is a big difference. Hope to make America great again, which was an old slide. It resonated differently, I think, the last time I said it. What are the recommendations? So this is for just, I'm sorry, I went forward one. That was elective PCI. It's really a class 1 level of evidence B, class 2A, indication. So it's kind of recommended, but softly. That's for stable MIs. What about for ST elevation? It's not even given a recommendation. It's just in the text, should be considered when feasible. I just went over all that mortality data. And while these are antiquated 2013, they have yet to be updated, although there have been updates. They just haven't included transradial. For ACS, it's not even mentioned. It's a 400-page document, and you can search for transradial, and it doesn't even come up. So it's really remarkable. How does that compare to ESC? This is their equivalent guidelines for ACS. Or that's for STEMI, sorry. It's a class 1 indication with level of evidence A. It's the strongest possible recommendation you can be given. How does that translate into utilization? Most practitioners try to follow guidelines. This is, again, cath PCI data from the NCDR, 3 million cases. Now, granted, it's 2007 to 2012. At that time, 16% of people were getting radial STEMI, but really the sickest patients, older than 75, those that had STEMI, this is all comers, those had STEMI, women, and then those that lived outside of the Northeast were less likely to get radial PCI, despite the fact that the outcomes were similar. A more recent publication, 2016, showed that we've made it up to 25%. This is data from the VA, so those that work at VAs at the CART system. In 2009, it was 5%, up to about 33%. The most recent statement by the SCAI is that 50% of elective PCI. So it's good, but it's still not even close. The other problem is that those that are getting the PCI, those 50%, are actually the least likely to benefit from it. So there's a spectrum of risk. So this is showing the risk treatment paradox, which shows that this group here, this is predicted femoral risk. So low, intermediate, and high predicted femoral risk of bleeding. You would think the more femoral bleeding risk, the less femoral use there would be. But it's the opposite. You're more likely to get femoral procedures, which is obviously a paradox and not in the patient's best interest. This is for STEMI. 2000, I think that's a 16, we were up to 25%. To put that in perspective, this is a trial in Europe, the Validate Sweetheart trial, but you could look at other ones. It was really not a radial femoral trial, but it was anticoagulation. And you can see here, 6,000 patients, 5,500 of them got radial procedures. It was operator discretion. So it's a 90% use in Europe compared to 25% here. It's massive. again, given the data that I've presented. So it really comes down to patient selection too, to do this well. I think people fail, they have bad experiences, or they struggle with kind of embarking on this, which is a shame because it shouldn't be that way. Don't make it hard on yourself. So older patients, prior CABG patients, very short patients, they have higher risks of having an unsuccessful PCI to start. This just shows the effect of height, 5'4" or less. That's when the risk of failure goes way up. This is another score that looked at 1,600 PCIs. Why did this relatively experienced center fail? Shock patients, bypass patients, CABG patients. Now it's tricky because those are the patients that are most likely to benefit. So it's really about working your elective practice to a point where you can do these cases with a higher success rate. It's important to understand complications with any procedure because they're different for transradial and especially for those taking care of the patient in a kind of immediate post-procedural setting. Radial artery occlusion is the biggest one. This is an angiogram showing that the vessel can thrombose, and there's dual circulation, so it's generally asymptomatic, but this is the palmar arch filling and showing the radial artery occlusion. What causes that? Sheath size. Okay, the bigger the artery sheath to artery ratio, the more risk of radial artery occlusion. To that end, engineering has improved to these slender sheaths most of you know about, where the inner diameter it could be a 6 French, but the outer diameter is that of a 5 French. Anticoagulation, it's really important to use anticoagulation, and we've always feared this because of the transfemoral bleeding risk, but you can be liberal, and we know that you have to give full anticoagulation, 5,000 at least, in most patients of normal body weight, and that's a big correlation with RAO risk. Even if someone's on Coumadin with a therapeutic INR, it's not the same, they still need to get heparin. What about how we close these? Patent hemostasis. So in the aftercare, most are familiar with the TR band, it's really critical to make sure there's patent flow even though there's hemostasis. How do we do that? There's different ways, but this was a trial showing what are the effects of it. So one group had patent hemostasis where the pressure was just above the map, the other was above the systolic, so totally occlusive. You can see a major difference in RAO risk. Practically, how do we do it? A reverse Barbeau test many are familiar with. The TR band is placed with hemostasis because there's no blood coming out, and you occlude the ulnar artery, and if the radial is patent, you would still see a proper waveform. If you don't, then it's obviously abnormal and you have to release some air from the device. Patent hemostasis, early and late reductions in RAO. There's some newer stuff even. I mean, again, if we all practice proper patent hemostasis, we would be great in terms of radial artery occlusion, but this shows what happens if you occlude the ulnar artery for an hour while you're doing patent hemostasis, like purposely occlude the ulnar to promote flow through the radial, and there was significantly less risks of RAO at the expense of a little bit more bleeding hematomas. Spasm, very preventable if you sedate and use proper equipment. I'm gonna go a little bit faster here. More common in female and younger patients. This is an angiogram of spasm, very dynamic. This is it's a dynamic vessel that responds. This is pre and post medication. So giving medications is really crucial. Don't use long sheaths. Really all the technology is so good now that it's really very little sheath related. In 17 years, I've had one catheter entrapment from spasm, so it's really not a real risk if you do things properly. The solutions are prevention, making sure people are not in pain, adequately sedated, and pre-medicated correctly with the radial cocktails. What about perforations? There's a lot of small, tiny little branches, and any little wire can perforate those and cause hematomas. Usually more common in the frail and those that are hypertensive. So you can be on the lookout for it. It's usually pretty obvious. There's different grades. Most of these are manageable with just simple external compression. What we really worry about is if it gets beyond that point and starts obstructing venous drainage and causing a compartment syndrome. The key is really listening to the patient, as I know all of you probably do. What about the patient's actual experience and the operator's experience? It's pretty clear also. Patients prefer this. Every now and then there's someone who requests a femoral procedure, not a radial, but I would say it's 20-1 in the reverse. This is old data. It's quality of life data. Every single metric was better with radial intervention, which is in terms of patient preference. This, I think, is compelling. That Rival trial, they asked up front to patients who got a radial or femoral procedure, the likelihood that their willingness to have a procedure through the same axis. So if they're randomized to femoral, they asked about femoral. If they're randomized to radial, they asked about radial. So it's basically an assessment of their experience with that. And you can see here, 90% of radials said they would prefer that same route, whereas only 50% of femorals. Now, the other 50% that didn't have complications, so we're not measuring them in the complication numbers, but half of them had an experience so bad that they didn't want it the same way, which really speaks volumes to what we care about with our patients, especially when there's so many options for them. The operator experience, there's a lot of stuff for physicians and staff in there: radiation, time, comfort. Basically, after about 50 cases, the radiation fluoro times flatten out. There is an association with more radiation, so you have to know that. Really it's significant in the low experienced people. It reduces, and you can see that absolute numbers reduce, right? The more experienced you are. But there's always a little trend towards higher radiation use. That was seen in radiation in the Matrix trial, where there was more radiation, this is radial versus femoral, at the thorax significantly, and the trend in the other areas. But to that end, this was an interesting thing. I looked at each one of these bubbles is a trial looking at radiation across time. You can see the gap. So the increased fluoro time of femoral versus radial is narrowing as we get more experience and do better. Ultimately, and this just shows, right radial has more radiation than left radial. That's at the expense of operator comfort. So the left radial is easier, but it's a little bit, in terms of radiation to engage the coronaries and things like that, but it's, a little more uncomfortable if your setup is not great. To that end, again, our documents are best practice as put forth proper radiation hygiene. And this is critical. All you guys are in rooms wearing lead. The operator needs to know these things, the person operating the pedal, to make sure people are leaded when they step on far away, shielding, and not fluoring when they don't need to. So avoiding routine fluoroscopy of the wire going up the arm if there's no resistance. Using fluorosave instead of cine. It's 1/10 the amount of radiation. And this is what this slide, which I think really shows it. It's not really about femoral radial, it's about the operator. So low radiation femoral operators are low radiation radial operators. It's really more about radiation hygiene than anything. Lastly, from the hospital's point of view, the bean counters love this. Length of stay is way less, 0.38 in this one trial of 7,000 PCIs, and that translates to a lot of money. And when there's more money, the administration's happier, and then a lot of things, more nurses, I was going to say it always trickles down. Probably it's like micro fractions of what it should, but it's good to save money even for the system. This is in England, which I think was a lot of socialized medicine is really logical to me, but anyways, it's a separate point. 300,000 patients. They looked at, again, length of stay mediated massive reductions and cost savings. So in summary, I went over here, I apologize. Transradial, it makes sense. It's really good for the patient. It's good for the staff. I mean, the fact that you guys are all here speaks to the fact that you care about your patients and your own work as it relates to your patients. It's really good for the hospital, and it's good enough for the rest of the world. So really, hopefully, you can, if you're not already in a radial lab, you can kind of take this back and plant that seed and put it in someone's mind. So anyways, any questions, I'm happy to try to answer. Thanks.